Menopause is a natural transition, yet it often brings challenging symptoms that can significantly impact a woman's quality of life. For many years, menopause hormone therapy, or MHT, has been a topic of both hope and concern. However, our understanding of MHT has evolved considerably, shifting the pendulum toward a more nuanced and individualized approach to care. At its core, MHT is primarily indicated for treating moderate to severe vasomotor symptoms, like hot flashes and night sweats, and it also plays a crucial role in preventing osteoporosis. The initial findings from the Women's Health Initiative, or WHI, trial, published in 2002, understandably caused widespread alarm and led to a dramatic decline in MHT use. Reports of increased risks for breast cancer, stroke, and coronary heart disease made many women and clinicians hesitant. However, subsequent analyses have peeled back the layers of this complex study, revealing a critical timing hypothesis. This reanalysis showed that the study population had an average age of 63, with many women initiating MHT more than 10 years past their menopause onset. Importantly, for women who began MHT before age 60 or within 10 years of menopause, the risk of coronary heart disease and all-cause mortality was found to be neutral or even reduced. The increased risks were primarily observed in older women, underscoring that the timing of MHT initiation profoundly influences its safety profile. This deeper understanding also extends to the method of hormone delivery. Oral estrogen, when taken, undergoes a first-pass metabolism in the liver. This process can increase the synthesis of clotting factors and decrease natural anticoagulants, leading to a twofold rise in the risk of venous thromboembolism, or VTE. Fortunately, transdermal estrogen, delivered through patches, gels, or sprays, completely bypasses this hepatic effect. It absorbs directly into the systemic circulation, avoiding the liver's metabolic pathway. Observational studies consistently show that standard doses of transdermal estradiol do not increase the risk of VTE compared to non-users. This makes transdermal estrogen the preferred route for women with VTE risk factors, such as obesity, a personal history of VTE, or known thrombophilias. For women with a uterus, progesterone therapy is a vital component of combined MHT. Estrogen alone can lead to an increased risk of endometrial hyperplasia and potentially adenocarcinoma. Micronized progesterone, rather than synthetic progestins, is often preferred for endometrial protection. It is typically dosed at 100 milligrams orally for continuous therapy each night, or 200 milligrams for 12 days a month in a cyclical regimen, helping to safeguard the uterine lining. Beyond systemic symptoms, many women experience genitourinary syndrome of menopause, often abbreviated as GSM. This encompasses uncomfortable symptoms like vaginal dryness, dyspareunia, which is painful intercourse, and even recurrent urinary tract infections, all stemming from the atrophy of the vulva, vagina, and bladder tissues. For GSM, low-dose vaginal estrogen is a highly effective treatment. Available as creams, tablets, or rings, it directly treats the affected tissues with negligible systemic absorption.
This means it carries minimal systemic risk. It doesn't increase the risk of VTE, stroke, or heart disease, and it does not require co-therapy with progestogen to protect the endometrium. This targeted therapy can significantly improve quality of life and is a key tool in preventing recurrent UTIs in postmenopausal women by restoring vaginal flora and pH. Of course, MHT is not suitable for everyone. It is absolutely contraindicated in patients with a history of estrogen-sensitive cancers, such as breast or endometrial cancer, as well as those with a history of deep vein thrombosis or pulmonary embolism or active severe liver disease. Undiagnosed abnormal uterine bleeding must also be thoroughly evaluated to rule out endometrial cancer before initiating MHT. While migraines were historically considered a contraindication for oral estrogen, transdermal estrogen does not appear to significantly elevate the risk of stroke in these cases, allowing for more individualized consideration. When initiating MHT, the approach is typically to start with standard doses and titrate based on clinical symptoms rather than relying on serum hormone levels. For healthy women with a uterus who are in early menopause, a common starting regimen might involve a 0.0375 mg or 0.05 mg estradiol patch, changed weekly or twice weekly, combined with 100 mg of oral micronized progesterone nightly. Patients are usually reassessed in 2 to 3 months, and the estradiol dose can be adjusted if vasomotor symptoms are not adequately controlled. It's worth noting that unscheduled uterine bleeding can be common in the first 3 to 6 months of continuous combined MHT, but if it persists beyond this period, further evaluation with a pelvic ultrasound and possibly an endometrial biopsy would be recommended. Finally, the duration of MHT should be a highly individualized decision, not dictated by an arbitrary stop date. Vasomotor symptoms can, in many women, persist for well over a decade. The choice to continue or discontinue MHT should be a collaborative one between a woman and her healthcare provider, weighing the ongoing benefits of symptom control against her personal risk factors for cardiovascular disease or breast cancer. For women who decide to stop, a slow tapering of the dose is often recommended to help avoid a sudden and severe recurrence of symptoms. In summary, the landscape of menopause care has grown more sophisticated, moving away from a one-size-fits-all model. Today, MHT is recognized as an effective and safe option for many women, particularly when initiated appropriately, using transdermal delivery when indicated, and tailored to individual needs and risk profiles. The nuanced understanding of the WHI trial, the benefits of transdermal estrogen, the role of micronized progesterone, and the highly effective local treatment for genitourinary symptoms all contribute to a more comprehensive and personalized approach to helping women navigate the menopausal transition with greater comfort and confidence.